Hi, and welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we do this podcast for you, veterinarians and technicians in general practice, every Wednesday. I'd like to tell you really briefly about a free live training that's available for you starting July 17th. It'll be live that day, and we want to invite you to come. The URL for that, just go to the International Veterinary Dentistry Institute website, which is ivdi.org/July. That'll allow you to register for this once in a lifetime training that may change the course of your practice lifetime. Hope to see you there, and let's get to the podcast episode for this week. As part of our efficiency series, where we're getting you to be more efficient or even more efficient. You're probably pretty efficient right now, but even more efficient in your dentistry service. And one of the things that we can do to enable that is to be cognizant of the order that we need to do things with the patient as we induce the patient and as we proceed toward the recovery of the patient. So let's describe that. This is easy to relay audibly on a podcast. So if you're listening in a car, you might not want to visualize this. You might just want to listen and then go back and write this down as we talk about it when you listen to the replay. But with the protocol that we're talking about, it's super important to be able to think about this every time that you start to implement it, have it written down, go through it, and in 5-10 cases, everybody will be on board, and this will make a huge difference in your practice lifetime, as many of these things that I'm passing on to you in this efficiency series, and create exponential time savings and make your life a heck of a lot easier, make the anesthesia a heck of a lot shorter just by doing these things. And think about it from the standpoint of doing something now that saves time later. If you don't take the time to do things now, it's going to create additional time wasting for the rest of the time that you wait in order to implement it. One example that's common, may not be as common today with you as veterinarians or technicians. It may be something that somebody else does for you. But think about when you opened up your first checking account and you had to set up the cash machine to take your information and spit out that cash. So I don't even know if they called them ATMs back then, but if you didn't set that up when your checking account was established or soon thereafter, then every time you wanted cash, what did you have to do? You had to go to the bank, which took a lot of time, go inside or sit in the line at the checkout, had to be when bank hours were open, and present them with a check for cash and get that cash back. If you set up the ATM service, you can go any time of the day at any location and very easily get money out of that ATM machine. So by setting that up, you've saved yourself loads of time over your lifespan. And I know that may be an antiquated example, but it's a really good example of what you can do from the standpoint of setting up something that may take a little bit of time, but once it's set up, it's going to save you time every single time. So this really doesn't take up that much time. So let's get into that. So protocol in your dentistry service from the time of induction to the time of recovery. First thing that you're going to do, obviously, probably your technician's doing this, is to induce the patient and then place an endotracheal tube. Hook them up to the monitors, and then the next thing that you do is really important as far as efficiency goes. My recommendation, what we've developed over the years and what we had trial and error with for a long time with dentistry in our early years is, what do you do next? Depends on the day, right? I mean, you make a decision, there's a lot of calculus on the teeth, let's knock that off. Or there's a loose tooth here, we're going to extract that. Whatever it is, that's not the way to approach it. You want to approach it from the standpoint of, this is the way we do this every single time without fail. And the reason is because it's more efficient. It makes it so that it's much easier to do when you are in that situation. Again, you don't have to make a decision. You've induced the patient. You then go to placing a towel under the chin to make that palate parallel to the table, or roughly parallel. And then you start your full mouth radiograph series with your templates installed, which we have talked about, or we will talk about in one of the efficiency episodes. And that way you can go around that whole patient within 8 minutes or less, taking all those x-rays. And maybe that even gives you time to take an extra x-ray or two, which if you follow our recommendations in the template efficiency podcast, you won't need to take many x-rays. You've got all those systems that are given to you that you can put in place that makes it so retakes are almost non-existent. So listen to that episode if you missed it, or if we haven't published that yet, it's coming up. Listen to it when it comes up. And then do those radiographs first, because what that means is you've got all of the indications on that radiograph, with few exceptions. They're going to dictate what extractions you're going to be doing. That's another podcast in itself. That's actually a course segment in itself, because it really takes radiographs to be able to walk through that and you be able to watch those radiographs be described, and arrows pointing at the level of bone and all of the parameters that are needed to make those decisions. But with that, the veterinarian who's competent at reading dental radiographs can look at those radiographs, take the paper chart, and X out all of the extractions that they know are going to happen without even looking at the patient. There may be some severe gum recession. There may be other changes in teeth that are not showing radiographic changes. So those can be quickly added to that chart with very little visualization. But I will say that those things are not very common. So if you just go with those radiographs, you're ready to call the client and give them an estimate. It's going to be this many extractions. We may find some other things when we clean and when we really get down to microscopically evaluating pockets and evaluating the patient visually. But we know that these teeth have undergone significant bone loss and compromise, which is anywhere from 25% to 100%. And so we'll get started with this if that's okay. The doctor will proceed to start the procedure. So we've already got that established. We know the estimate for the client. That's the majority of the estimate, 85, 90, 95% of the estimate. We're going to call that client back after we've done the next step, which is cleaning and probing and charting. So all those things can be done. We recommend that you do them with one side up in lateral recumbency initially, and then move the patient's head to the other side, do the other side in lateral recumbency, and then you've got your full evaluation of the vestibular, and also the palatal and lingual aspects of those teeth on that chart. You can call the client back, let them know that there's additional pathology there. In that whole meantime, what you can be doing and what you can do as soon as you get the go-ahead is put your nerve blocks in. So before you clean, before you do your evaluation, as long as you've got how many extractions you're going to do and what quadrants they're in, and you've got the permission of the owner, quickly before that procedure drags on from doing things inefficiently and not taking radiographs initially, then you're ready to place your nerve blocks. So you do the nerve blocks, you give them the amount of time it takes for you to probe and clean, and you're ready to go. Now, one question that arises often that needs to be addressed is, what about the calculus? There's a lot of calculus on those teeth. Is that going to interfere with my radiographs and my interpretation? And the answer to that is almost never. And almost never is pretty much never, unless you've got significant palatal calculus on the palate side. Because when you think about the angulation of the tube head where your sensor is, unless you've got palatal calculus that shows up on the root because it's superimposed from your angulation, you're not going to have a problem with that. So don't even concern yourself with that. I've had that happen maybe 3 times in practice, so it's almost never a problem. Take your radiographs, find out what your extractions are going to be, and when you're cleaning, the other thing for maximal efficiency is you don't clean the teeth that have the calculus on them that you're going to be extracting. There's no reason to do that. We're doing surgical extractions here. We're not touching that calculus. We're exposing the bone and mucosa. And so in most cases, unless it's an extensive amount that you want to break off with your extraction forceps, because it will get in competition with the head of the handpiece to properly angulate your burr if you don't do that. So if it's significant on the vestibular or buccal side, which is the old term, then you want to remove that quickly with extraction forceps. Takes less than 20 seconds to do a side, upper and lower probably. And then you're ready to go right into your surgical extractions. The other thing that is going to save you time in that whole process of cleaning, evaluating, and charting, you do not need to chart periodontal pocket depth on the teeth you are going to extract. The diagnosis you made based on those radiographs is enough to dictate the periodontal stage that you're dealing with. And the periodontal stages are not something you see grossly. It's only through radiographic evaluation that you can tell that it's stage 1, less than 25% bone loss. Stage 2, 25 to 50%. Stage 3, 50 to 75%. And stage 4, over that. So with that, you want to make sure that you are not staging and not putting down in your chart things that don't need to be done. You could chart several surfaces on those teeth you're going to extract and totally waste time doing so. And the reason it doesn't matter is when you come back, there's no pockets. The pockets are gone on those extracted teeth. The gingiva has grown over the alveolus. The alveolus is full of bone from you leaving a blood clot in there. So with that, the radiographs determine the stage of periodontal disease and what you put on that chart. the periodontal index or stage of periodontal disease. And that's what indicates your extractions. Anywhere from stage 2 to stage 4 is where you want to be. So that being said, and when I say where you want to be from a extraction standpoint and from a charting standpoint. So with that, the only exception to that, go back to what I said about sometimes you're going to find gum recession, severe gingivitis in areas that don't show up radiographically on your x-rays that you're also going to have to extract because they've reached beyond the mucogingival line. And if your tissue changes have gone apical to the mucogingival line, then that's an extraction every day. And so you would find that and you would chart that and you would add that to the extractions if that is the case for after you've already called the owner. And that's what you're going to do when you call them back. You're going to say, hey, we found additional changes after we got the calculus off, after we did our probing. And so those changes are significant enough to warrant extraction. They're going to be something we can't alter the progression of no matter what we do. If we leave that, it's going to progress, and so we need to extract. And it may be that there is severe bone loss, and let me qualify that with the radiographs that we take of the canines. The canines have super thin bone on the vestibular side, pretty thin bone on the palatal side and of the maxilla. Not as much of a problem on evaluating the mandibular canines because you usually get that bone gets thicker as it goes to the apex. You can usually pick that up. But on the maxillary canines, you may not see the bone loss because that bone's so thin and it's superimposed with your radiograph over that thick dentin that you're taking in addition to that thin bone. So you may not see that. And you may open that flap up and you have no bone on the tooth root. That tooth root is further than your recession is even void of bone. So those are instances where you may not see radiographic changes, but you see severe inflammatory changes, proliferative changes, gum recession changes that dictate extraction. So once all that has happened and the veterinarian has gotten in and done those surgical extractions, which may take an hour and a half, may take 3 hours, depending on how many teeth you have, and have closed, one thing that you definitely want to do, and this is not necessarily part of the efficiency part of that equation, but this is part of the patient safety part of that equation, and we have this on Instagram. We've probably got it on YouTube. If you search for it, we've got it in our courses. But that's how to look at the back portion of the oral cavity, whether you put a piece of gauze in there or not, and take gauze and then cotton tip applicators and remove any mucus and blood in the trachea, around the trachea, particularly if you've done extractions of the maxillary canines or the maxillary teeth and there's communication on the palatal side from bone loss or otherwise, and you get nasal bleeding. Not only is that going to come out orthograde through the nasal, through the nares, it's also going to be retrograde to lie possibly as a clot on the top of the soft palate. So we milk that soft palate from the hard palate to the tip of the soft palate, and almost inevitably we're going to get a huge blood clot that's going to come down into visualization in that caudal oral cavity, and you'll be able to remove that easily with a cotton tip applicator. And essentially what we're doing is we're eliminating mucus and possibility for obstruction over that tracheal lumen. We're also eliminating any mucus and blood in the trachea, and you need to do this carefully. It's not a real technically intense procedure. You just have to have a really soft grasp of the cotton tip applicator as you place it so that you're not jamming it anywhere, and allow that soft grasp to dictate how far down you go. And you're looking at this. If you've got your magnifying loops on, you're able to see down in there. And I would suggest that as veterinarians, you are the one that's doing this initially. The technicians, if they're highly trained and know oral anatomy, which your dental technician eventually will, they can do this. But I would be more reluctant to delegate this than most anything that we do. We have never had any problems with going down in the trachea with tracheal rupture. We have had what we suspected was one tracheal rupture in a cat that resolved spontaneously. That was not a clinical issue, but that can be bad, and that was from maybe an overinflated endotracheal tube. So that being said, it's almost non-existent to have problems with that approach to removing anything from the trachea. And what that gets you is the peace of mind and the experience inevitably that clients are not calling back, trying to reach you after hours, calling back the next morning saying that the patient coughed all night. And we've always attributed that, and we did too, to overinflation of the endotracheal tube. And now, not overinflation, I'm back to the previous thing we were talking about, of just the endotracheal tube being in the trachea and causing irritation. And now that we've been doing that for 10 years, we don't see that as a problem from the clients calling very often. Occasionally we may get that, and if we do, it may be because there was a little blood left in there, a little mucus left in there that we couldn't get to. Or it could be irritation from the endotracheal tube, or both. But it's so infrequent that it's not a problem, and that in itself saves you time and your receptionist time, and or you being you as a veterinarian or a technician, talking to those clients and assuring them, getting the patient back in to make sure it's okay, inconveniencing the client with the coughing in the first place. So you're eliminating all those variables just by doing that one thing. So I hope you enjoyed this episode. Again, if you haven't registered yet, go to IVDI/July. The International Veterinary Dentistry Institute is sponsoring the free training that I'm going to be doing then. And IVDI is our training arm of our teaching. And so you're going to really enjoy that. Don't hesitate to reach out to us on Facebook or otherwise. Make comments in this podcast where you hear podcasts. Rate and review us if you can. We'd love to have that if you like this. Or if you don't like it, certainly give us a rating and review, an honest rating and review. So hope, again, you enjoyed this episode. You take it and you actionably institute it in your practice this week. If you don't do it this week, it's probably not going to get done. It's going to get shoved into something else taking priority. So as we do these podcasts, we mean for them to be something that you institute every week. So please take that advice, institute it. You won't be sorry, and we'll see you on next week's episode.